Hello, everyone. Hi, I'm Aditya Bansod, and welcome to Digital Health on Air. I'm joined by Nick Healey, a partner at a major law firm, Husch Blackwell, focusing on mergers and acquisitions. Nick joins us today to share his perspectives on rural health and how organizations can best stay independent if that's their desired path, even in a very challenging financial climate. Nick, welcome to the show.
Thank you. I'm happy to be here.
So, Nick, you built your career kind of in the Mountain West. You're based in Wyoming and have kind of really seen firsthand how rural hospitals and rural care delivery helps their communities. Can you just maybe warm us up, start us with a little bit about kind of what you've seen as the challenges they face when you've consulted with these rural hospitals, independent providers, FQHCs, and other safety net organizations?
Yeah, happy to share some background on that. I think one of the big challenges that a lot of rural healthcare providers face is, it's easy to say staffing, but essentially finding the right people to provide the right care in a rural environment. It isn't easy. It takes a different mindset than most healthcare is delivered in, even down to the scale of the landscape. I worked with a hospital chain for a while that its headquarters was in New Jersey or something like that, but it had hospitals all over the country, and it would periodically rotate the CEO through the hospital in a really small remote town in Wyoming. And it took almost 2 years for the CEOs to just get a sense of distances, especially in the West. It's rural in a way it's not rural in other parts of the country, because if you're in Iowa or Missouri or, Arkansas or some other town, some other city, some other state that is primarily rural, you may have a town of 10,000, 25,000 every 20, 30 miles. Here,
Sure.
you can have 200 miles between towns of 5,000. And so just getting people to understand, just distance, the landscape, that kind of thing is a real challenge. The dog problem.
I can definitely hear the dog, but I think
No.
let's,
Okay,
they can
sorry.
come in if they want to and join the show.
Right. So that would be, that kind of mindset it takes a while to adjust to providing care in a real frontier environment out in the West, in the rural parts.
And when you think about kind of like, let's look at that CEO example, it's like probably like a site visit to go to like a clinic. It's not like an afternoon, it becomes a whole day long affair. Do you find that like there were techniques or what did people learn after they did those 2-year rotations? Like, how do they figure out like, this is different and this is how I need to address it?
Yeah, that's also a great question. How did they learn to address it? I think they learned to deal with it by preparing the people who sent them, people in the home office, educating them about the specific challenges faced by providers out here. Just getting them to understand, not just the people on the ground who rotate through, but getting people in the home office to understand both the culture and, the scale of geography out here, so that they can allocate the right resources to make rural healthcare successful in the West. That's laying the groundwork. That's probably the most important thing. Laying the groundwork with the decision makers is really important. And like you say, the costs of providing care in a frontier environment are challenging too. There's a lot of rural hospitals that have visiting specialist arrangements where they have contracts with, other hospitals or clinics to come from a larger center to the rural hospital and provide care in a clinic, and then potentially do surgery there or provide other types of care. And as you said, it is an all-day affair. When a visiting specialist comes out from a larger center, it can be a multi-day affair.
Yeah.
It's not simply you drive for an hour to the rural place and then provide the care and drive home. It can be very expensive to pay for a specialist to be out of the office for multiple days to come to your facility and provide very advanced care. So that kind of cost is not something that people in larger centers ever really think about.
One of the Luma customers we work with, actually quite a few of them operate kind of in the Mountain West and kind of, where I joke that you have to zoom out on Google Maps like 4 times before you can find like a recognizable landmark. And the amount of work that goes into providing ancillary care like cardiology or orthopedics, they'll often have like a jet or a plane fly in, this physician. They will have a special housing available for the traveling care teams, which I think in the theme of today's episode, really around staying independent, you have to provide some of these services in order for, your patients to still come to you. And so when you kind of look at the M&A trends that are happening in the industry, do you see this need to bulk up so you can provide more care, or do you see that like a lot of folks are still trying their best to like be really community rooted in the last couple of years?
Yeah, and I don't think that's an either or kind of thing. I think they certainly can remain community rooted, while at the same time building up their own resources to be able to provide broader ranges of care. And one of the trends that appears to be going on in rural areas right now, it used to be that people in rural areas preferred to get more advanced care, anything beyond routine care at larger centers. And now
Sure.
the aging population, a lot of people don't want to travel
Yeah.
to get care. And so they're really requiring more from their local facilities, their hometown hospitals and clinics and those kind of things. And so to respond to that demand, a lot of rural healthcare facilities are really bulking up their service line offerings. Yeah, go
At
ahead.
least I'm curious if you've seen this trend because it kind of echoes what I've seen, which is, you have a lot of safety net hospitals, critical access, 25 bed and under hospitals, throughout the major, like, every 60 miles on a large interstate, right? Or in your case, 200 miles on a large interstate. But what maybe this ties into what you've seen too is I've seen these hospitals now try to have a primary care location, maybe an outpatient orthopedic location, some other parts that are not just the hospital at the center of the town, but also some other kind of services that are a little bit further from the town center. Have you also seen this as well, or is it kind of like I've got a little bit of tunnel vision here?
No, I think that's true. And that, is in a lot of ways, it is the trend to provide more care in outpatient facilities as opposed to centering it all in a hospital. The thing is, especially with, small hospitals, critical access, that kind of thing, there's not a lot of outskirts of town, right? Like
Yeah,
it's in
the
your house.
outskirts. It might be a
Yeah,
farm, right, or it might be a
exactly.
factory, right?
Yeah, the larger rural hospitals in towns of 25,000 or so do tend to have outreach clinics in, in outlying areas, maybe 50, 100 miles away. They have their own hub and spoke model, essentially. So they're replicating what larger centers are doing in that respect. And then, a lot of rural facilities, in a bid to sort of remain independent, they do enter into affiliation agreements with, especially academic medical centers. And in this area of the world, the CU Healths or University of Utah.
Yeah, those tertiary care
Yeah.
centers.
So, they end up being a spoke on the hub for those tertiary care centers, but then they have their own spokes as well, reaching out into the really small places. So that's a long way of answering your question. Yes, I have seen that. But, again, in kind of the frontier environment, there's, not a lot of people talk about 15-minute cities. We are 5-minute cities. It doesn't take a lot to get from here to there. And so in a lot of towns, yeah, you may get outlying clinics and things like that, but simply because the cities themselves aren't very big, that tend to be this healthcare tends to be concentrated on a campus still.
Right, and in a very central location, it makes sense, and, you spend, I think, in your through your legal practice, a lot of time with leaders in these organizations and folks like this, because through some of the reasons that rural hospitals that you've talked to, they wanna stay independent, and maybe putting a little frame on this or a little context around it, which is I think the financial times obviously are difficult. You have the recent budget, which may make some of that a little bit more difficult. You have, consolidation from those tertiary care centers, which may put pressure when you could do 200 miles this way or 200 miles another way and find a large tertiary care center. But what are the reasons you hear from these hospital leaders that they want to stay independent, that they want to stay rooted in those communities?
It's completely driven by the community itself in most cases. There are the outliers that you may get a very strong personality at the head of a hospital that doesn't want to, answer to somebody else. But for the most part, a lot of them are governmental organizations. They're, special
City
district.
owned, county owned. Yeah.
Yeah, city owned, county owned, special district owned, or they are nonprofit corporations that have been created by the community, and they tend to be very, very responsive to the community itself. They're not for-profit organizations. And so, they really are responding to the needs of their neighbors, the people they see in the grocery store. And from experience, I can tell you that, when you're making unpopular decisions from a hospital's perspective, you get that feedback instantly, right? In the aisle of the grocery store when you're dropping your car off to get it fixed. People have opinions about, they tend to feel very attached to these community facilities, and they end up giving you that feedback loudly, often, and when you least expect it. And so I think the biggest reason is really because that these hospitals want to stay independent because it's the best way to serve their community and remain responsive. A lot of them do end up, as a spoke on a tertiary care center's hub. And I think they get some experience in a lot of cases that the hub is not particularly responsive to their needs, and end up in the grocery store aisle talking to your neighbor and having to answer for decisions that are made in Denver, Salt Lake, Billings, Rapid
Tens of
City.
thousands of miles away.
Oh,
Yeah.
right. Yeah. Nashville, Phoenix. So yeah, so really it's just an attempt to be responsive to the community that they serve. And the other thing that is one of the drivers is the people who get drawn into frontier healthcare tend to be incredibly community minded. They're not,
Yeah.
it is a career, but at the same time, it is a service. They're serving their community and they take that incredibly seriously. So it tends to be kind of a natural thing for them to want to remain independent and have the most responsiveness to their communities that they can have.
Do you find that there's certain, I mean, I love that idea, that concept of when, if you're walking to the grocery store, you find somebody who's your hospital admin, you're like, why did you remove the service line? Why did you close the L&D ward? Why did you do this? Like, this is where my kids were born or whatever it was. I think that's just a really powerful way to keep these, keep rural hospitals connected to the communities they serve. So let's maybe use that as an opportunity to talk a little bit more about, what we've seen in the world of M&A and some of these, because we started talking about it, either the affiliation or they end up being linked up to some larger system that has, headquartered in Phoenix, LA, New York, whatever it is. Are there structures? Are there ways of governance? Are there ways that you've seen successful that have let these organizations stay independent versus other ones that may have not necessarily, whether it's a special district or city owned, or, how have you seen these things be successful where they can actually still walk into the grocery store proud of the fact that they kept the L&D ward open?
Yeah. Yeah. L&D is actually a really interesting area because so many rural healthcare facilities are having to cut L&D because they can't provide the service anymore. They don't have the personnel. It tends to be a challenging payer mix for those services. So yeah, that's one that cuts close to home. Actually, Wyoming has a governor's task force on maternity care that has been meeting for about 2 years on trying to figure out how to better provide those services, that's a tangent. So yeah. So structures to affiliate with tertiary care centers that work well. So I've seen a couple of different models.
Right. So Nick, I mean, what are some of the structures, whether it's special districts, city owned, that you've seen that help these systems really stay independent, that have prevented them from maybe kind of going the way of getting gobbled up by some larger system?
Yeah. A couple of different ways to do that, especially in the West, the rural West. Going the governmental entity route and creating a special district that has the ability to tax the properties that are in the district and raise money that way. That tends to be a pretty successful model. Definitely, the success of that model fluctuates with the value of property and an economic activity in the district itself, but at least it gives you a funding source that is a little bit decoupled from what goes on in the healthcare industry in Washington, those kind of things.
Right. So you can be a little bit less policy oriented.
Yeah, a little more community oriented. And it's also those special districts tend to have elected boards, which tends to give you, again, really direct feedback from the community. There are some challenges with those kind of structures because they tend to be very political, but I've seen quite a number around the West be very successful over a long period of time. Definitely, special districts are helpful. County hospitals, similarly, as long as the actual running of the facility isn't too influenced by the county and potentially competing priorities. But those are two. The other model that's very prevalent in the West has been, as we said before, the hub and spoke model, where a large tertiary care center affiliates with a rural hospital and agrees to provide specific resources to it, which can be anything from visiting specialists to assistance with back office functions like compliance and billing, credentialing, medical staff services, those kind of things, as long as the rural hospital has good advice on the front end in terms of, recognize what you're potentially giving up, that can be very successful. Some of those tertiary care centers want to have a very strong hand in running the outlying facility. Some don't. Often they're their involvement will be limited to having a board member either in a representative or advisory capacity. But a lot of those, the rural hospital tends to have a lot of input at the front end on how those affiliations are structured, and they can be pretty successful because the rural hospital gets to write its own ticket in a lot of respects. I think the last one that I've seen with varying levels of success is a lot of governmental entities will lease the hospital facility or the healthcare system assets to a private company and include very detailed performance metrics in the lease itself, with an option to potentially take the assets back in whole or in part, if the private company is not running them in a way that allows them to meet those key performance metrics. So, that can be very helpful. It tends to keep the tertiary care centers or private companies honest when there's the potential they may lose any investment they've made in it because they aren't doing a good job or being responsive to the community. But at the same time, it also requires a significant level of expertise on the part of the governmental entity or nonprofit corporation that owns the facility or the assets, because they need to know what performance metrics they should be.
They've got to know what to ask in the
Yeah.
first place, right?
And how to track them, how to analyze them, what the output actually means, what the numbers mean. So, that's 3 examples of structures that I've seen with varying levels of success. Again, in such a challenging environment, there are probably less success stories than there are failures. But, I think people are being pretty creative at this point with those basic models and coming up with things that work for them. And so, knock on wood, we'll have resilient facilities that are serving the rural areas in this part of the country, and we won't see too many go under in, the coming years, as unfortunately has been predicted.
Yeah. So maybe like as a thought to wrap up, you've had such a wealth of knowledge on kind of how and what. If I was a administrator of a rural health system in the Frontier West, what advice would you give me to stay independent? I'd love to kind of close with, Nick's, your thoughts on how should I, with all your lived experience, stay as my own shop?
I would say 2 things. One, get a really good CFO. That kind of experience, one that really understands the challenges that are being faced by facilities in this part of the country. There's a lot of facilities that'll have nationwide talent searches for key positions, and they'll get someone who has a glowing resume from a large metro area. And those folks, it's really hit or miss. It can be really challenging for those folks.
It's just a different job altogether,
Yeah.
even though the title and responsibilities may be the same.
Yeah. And the other thing I would say is know your community, know and respond to your community, and don't bite off more than you can chew. I mean, your community of 2,500 people is probably not going to need a full-time neurosurgeon, right? No matter how much large donors may howl, that's what they really, really want. They want, to be a world-class destination for neurosurgery. Most of these places are community organizations, community facilities. Know your community, know what your community really needs, and do a good job at the basics. That's a whole bunch of ideas kind of in a couple of words, but that's essentially what I would say.
No, I love that, Nick. I mean, just hiring a great CFO who understands rural care and then knowing the community for the kind of services that they need are great points to kind of close our episode of Digital Health on Air, really helping our listeners, many of which who do run rural health systems, understand how to stay independent in the face of growing pressure, shrinking payments, and growing competition. So, Nick, thank you so much. Truly appreciate your time, your expertise, and the words of wisdom that you've shared with everyone today.
Happy to be here, and thanks for the opportunity.
Cheers, Nick.